Hello, and welcome to the Opioids in Indian Country Learning Community Series. This is part 3 of our 4-part series. My name is Mardella Sunshine Costanzo, and I am the Broad and Focused Technical Assistance Task Lead for the SAMHSA Tribal TTA Center. On behalf of the Center's Contracting Officer, Representative Maureen Madison, and Alternate Contracting Officer Representative Jan Dunbar Cooper, as well as the project's co-directors, Lori King and Gloria Guillory, I'd like to thank you all for joining us today. In a few moments, we will start our presentation in a good way, but first I'd like to take a moment to review our process. Today's webinar is being recorded and a replay will be available in the near future. Because we are recording, all phone lines will be muted to minimize outside noise, but please do not hesitate to use the chat box for questions throughout today's session. Today's PowerPoint is available for download on the lower right side of the screen. Just left-click the file and a Download File button will appear at the bottom of the box. Clicking the button will start the download automatically. Finally, we appreciate you completing a brief participant survey that you'll receive at the end of today's session. This helps us better tailor our events to your needs. At this time, we would like to move forward with opening our session in a good way. Doing that for us today will be one of our Native Connections Grant Technical Assistants, Mr. Hunter Denia. This time I will turn it over to Hunter.
Bonjour, Gisa Najishnakas, Wabjan Shido Dem, Mount Pleasant, Michigan, and Doljaba. Come from the federally terminated tribes of the Saginaw, Swan Creek, Black River Bands of Chippewa, and Grand River Bands of Ottawa and Anishinaabe. I'd like to sing this opening welcome song for all of you today. Miigwech.
Thank you, Hunter. At this time, I would like to introduce our facilitator for today. Serving as our facilitator today is one of our colleagues, the SAMHSA Regional Administrator for Region 5, Captain Jeff Cody. At this time, I will turn it over to Captain Jeff Cody.
Thank you, Mardell. I appreciate it. This is Jeff Cody, and for those of you who have participated in our previous webinars, this is the third in a series of 4 webinars. Our previous webinars, we talked about the opioid crisis and how the Tribal Action Plan, the TAP, could be used as a planning tool and instrument to help tribes address the broad impact of the opioid crisis. We also talked about the use of naloxone, the importance in terms of this life-saving intervention and making sure it's in the hand of our first responders and those family members and loved ones and those people who are using opioids. In our second session, we talked about the importance of medication-assisted treatment and how to implement medication-assisted treatment in a culturally appropriate manner. And this particular webinar is going to focus on the importance of recovery and recovery supports. We have multiple different presenters today that I'm happy to introduce you to shortly. I'd like to note that in the past webinars, my good partner and colleague, Chris Poole from the Bemidji area, has participated also as a co-facilitator. However, he is unable to make it. We are very fortunate, though, that we have individuals from his office who are going to help first talk about the use of digital storytelling. So I would like to introduce everybody to Michelle Archuleta, who works in the Bemidji area office, along with Mindy Bird and Amanda Mulker, who are going to talk about digital storytelling and how it can be very useful in terms of recovery supports. So Michelle, I will hand it over to you.
Thanks, Jeff. Good afternoon, and thank you, Samsha. This is a first invitation, an opportunity for us to present our work using digital storytelling that we have actually kind of evolved into a story work toolkit. And so with me to help with this presentation, I have Amanda Mulker. She's a licensed alcohol and drug counselor who's been working in the field since 2011. And Amanda provides services to clients in residential and outpatient settings with adults and adolescents and families. And we also have Mindy Bird. And Mindy Bird is a certified alcohol and drug counselor. She has over 20,000 hours of documented individual and group counseling hours. And she's a member of the Blackfeet Nation. And so these two young ladies are going to help share with you guys in the world of behavioral health their experiences using strategies of digital storytelling and then also the wider concept of narrative processes and story prompts. And we've bundled this all together in a story work toolkit where we see it, just as the title says, it's the power of story for healthy living in Native communities. So with that, I do have to acknowledge two important women in the field of story who've laid down, I would say, a good path for those of us in this field, and we need to honor them. And so Joanne Archibald, she's credited with her work with Indigenous story work. She's been a doctoral student and now a researcher and a professor, and she focuses on how stories have the power to educate and heal the heart, the mind, the body, and the spirit using the Coast Salish knowledge systems. And then secondly, I have Carolyn Kenny. She was a cherished Native elder, researcher, and academic advisor. And in her recent work, she really has made a case for story being an embodied concept for Indigenous leadership. So I am going to move on, and here's our objectives for our presentation. And we kind of see this as laying out the path of learning how to use story and story work for health knowledge, gainment, how to improve a health behavior, and how to support individuals in a group environment. But I do want to say also, I am really not of the world of behavioral health, so I do feel like an outlier. But in my use of story work and these narrative processes, I really have seen the connection, and that's how Chris Poole and I really, we bonded over this, over the story work toolkit. And he, I was kind of kicking and screaming and saying, Chris, I don't know if this would fit. And he was saying, yes, it does, Michelle, with this group. So I do want to say I blame Chris. So now I want to move on to this. This slide in the presentation really kind of helps us understand and situate the context of health. And it really did for me because in my world, I really focus as the health promotion area consultant for the Bemidji area. I'm really focused on that bottom 30%, these health behaviors. But I'm also part of the clinic care with acute care, and that's 10%. And we all know that story that, you know, that's a big slice of the pie where funding and resources go. But what I've learned in my time here in the Bemidji area in working with tribes and urban programs is these social and these economic factors, these social determinants. And that really kind of helped broaden my own perspective because I felt it was probably narrow when I came here. Because you know, I kind of bought into that, these lifestyle behaviors, these lifestyle choices. And so knowing the role of poverty, education level, our social connectedness, housing, you know, how many people are living in a single house, and transportation, that all impacts our health and how we see our health. And so when we went out and did digital storytelling workshops, you know, as much as I was trying to sort of shift the conversation to a health behavior, our participants were really talking about that 40%, these critical factors that impact that health. Because it was the boarding school situation, the historical trauma, the generational trauma. It was the loss of language, cultural identity that was disappearing for themselves and their families and their communities. That's what we heard. So we knew that that was really key to health. But we also knew that, well, how do we help that and translate it into some type of chronic disease prevention activity? And that's where we really kind of came into story. Because we started hearing more and more about how through that ACEs science and the ACEs research around adverse childhood experiences that I'm not an expert in as much as you all on the audience are, but I started to wonder out loud, well, how do you help someone in a Native community make that shift and learn a new story? And that's what we saw with our digital storytelling program. We saw over 3 days when we started teaching digital story, the shift, the transformation of when they came into our workshop to when they left after they created that story and they were able to like say out loud what that story was for them. So, so that's a little bit of background in terms of understanding the context of health. For our health promotion program, this slide just shows you how we started. We started in 2010, and we simply started going out into communities to create stories. They were personal stories, they were health stories. Then we started moving into that broader concept, but then I guess we took it to the next level, and it became a 2.0 version, and we created this toolkit for educators and service providers to learn how to use story processes. So that's really what this is. This slide, kind of, if I had more time, I would go into it more detailed, but simply from my world, I had to kind of even justify, well, why use storytelling for health promotion? I know it makes sense in your world, but in my world, I grapple with that, and I almost have to make a case for it. So this comes from the great work of Lynn Gubrium over in the University of Massachusetts, and she talks about how it's storytelling for health promotion from a sense-making perspective. It helps individuals assert control and cope and transform, and we saw that in our workshops. It's building community, and you all know about using story to overcome challenging conversations. But overall, we know that stories are universal, they're intimate, they're honest, and I guess the gift is they don't tell us what to do. They're a metaphor. So our project, this story work toolkit that Mindy and Amanda are going to talk to you about from their applied use, really came about back in 2016, and it was a 3-part collaboration. So it was our Bemidji area health educators, our Minnesota Department of Health SHIP grantees who work in tribal communities, and we brought on Story Center to help us craft I would say, some kind of object, and over time it became known as the toolkit. So that's what that is. And so this slide really kind of just positions elevating the role of storytelling and story listening and how we wanted to create and make the case as an intervention for positive change around lifestyle choices and around resiliency. And so we see story, and you're going to hear this from the 2 next presenters, we see story as being the teacher. And I think that comes from the work of Joanne Archibald. And that's really what we are really hanging, I would say, our toolkit on. And so, in essence, the toolkit is a 94, it's kind of lengthy, I guess, but it's 94 pages of strategies and tools and processes for you as service providers and educators to use that can go hand in hand with other existing curriculums or other types of guided discussion prompts that you use. And you can see it's all meant to foster participant capacity. It's really meant to help ourselves as the facilitators best engage and best provide a group cohesion and bonded environment. I would say really that's kind of the goal of it. And so this was probably a 1.5 years in the making. We recently gave our toolkit a test drive, and we did this back in January, February, and March of this year. And this is where I met Mindy and Amanda, and they became test drivers of our toolkit. And they took the toolkit back into their work setting, and we wanted facilitator experience feedback. And so in this presentation, you're going to hear some of their personal experiences and some of the overall data that we collected on the test drive of the toolkit. Overall, it was very favorable. We're going to make a couple of revisions, but for the most part, I mean, I think we were able to accomplish what we thought we wanted to accomplish in terms of building capacity of facilitators and service providers with group delivery. So this is just a little slide of what we thought of with evaluation questions, asking facilitators about their experience, and even thinking about this presentation. I'm not going to go over this, but if you want to learn more about it, please contact us offline, and we're happy to send you our facilitator experience data if you'd like it. And so let's see. This one, though, I do want to share. We had 10 facilitators contributing to this data in terms of the facilitator responses. They came from Mille Lacs, they came from Oshkosh-Manitou, the Chicago urban community health program, and then a program over in Oneida. And we were able to reach approximately 50 participants through our facilitators. And we had an age range from pretty much 40 to 60, but we put in 10 because we had a participant, I think a parent brought a child. And so our second part of the presentation is I'm going to pass it on to Amanda. And Amanda is going to talk to us about how she has used this toolkit with the Oshkosh-Manitou group program that she oversees.
Hi everyone, thank you so much for having me. Having been in the recovery field since 2011, I've had the opportunity to work with and utilize many treatment modalities. Within the recovery field, the idea of story, or specifically telling one's story, is a powerful tool. Story opens up the doors of connection and unburdens those struggling with the weight of carrying their own stories. Story allows people to connect, heal, and transform. This is the power of story, which I found to be so exciting about initially attending the training with the Storywork Toolkit. Since bringing the toolkit to our program, it has merged incredibly well with the recovery work Mindy and I are currently doing with clients. So in this part of the presentation, we're going to discuss a little bit about CD treatment and addiction and how the toolkit has helped both elevate our work as well as take it a step further. Up above, you're going to see some of those goals of CD treatment as well. Basically, what we really want to do is educate, provide opportunities, and do some prevention and give clients a really safe space to do those things in. This is a definition of addiction from the ASAM. The biggest and best part of this definition, I feel, is that the bottom piece, without treatment or engagement in recovery activities, addiction is progressive and can result in disability or premature death. Everyone knows at this point what addiction is. We're all becoming really familiar. We all have families or people we know or ourselves that are in recovery. But what this says is it's got the stress of importance of treatment engagement. This definition doesn't describe the problem, but provides a course of action. When clients are able to utilize treatment to engage in recovery activities, they are essentially using tools which will help with their individual recovery and transformation. Allowing clients this opportunity to reframe the old ways in which they see themselves greatly encourages movement from addiction to recovery. So themes from some of these stories, some of the benefits participants and groups from using the toolkit. Basically, what they have found is a lot of deeper engagement. Things are kind of having a different flow. There's more of a connection. It inspires. It lightens the mood. It really helps facilitators use the story as a co-facilitator to change the flow of the group to really benefit participants. This is a beautiful TED Talk, and it was done by Johann Hari, and he stated in there, the opposite of addiction is not sobriety, the opposite of addiction is connection. This is absolutely a wonderful talk. If you have the time or are looking for it, you can definitely look that up on YouTube or anywhere online. So how does the toolkit relate to addiction and recovery? Michelle has this wonderful quote, which is in the beginning of the toolkit. And we found this in there when we started the training. The slide was at the beginning and made an impression. Through working with the toolkit, Mindy and I have experienced a personal transformation in the way we facilitate, as the toolkit has been a platform to support more positive change in those we work with. So much of what she discussed is part of what we work with daily with our clients in recovery. Story work is recovery. Often we turn a deaf ear to being told what is best for us, but story is different. It convenes people. It draws them together through empathy. It allows people who are struggling with their health to feel less alone. It plants seeds of change. Since the beginning, in the world of CD, story has been utilized in many formats, including but not limited to talking circles, step work, 12-step formats, life stories, inventories, etc. So in using the Storywork Toolkit approach, CD groups are so incredibly common and well-supported modalities of treatment. As noted in this slide, groups are a beneficial modality as clients can support and encourage each other in ways facilitators are often unable to. Some of the ways stories are utilized include which they do. Treatment group setting stories are utilized as a co-facilitator as they create a natural flow into the most common interventions. So as part of a natural flow into our presentation, I would love to introduce my toolkit co-facilitator, Mindy Bird. Good afternoon, everybody. I'm catching a bit of a cold, so I'll try to last as long as my voice lets me. As a group facilitator with the intensive outpatient program, I immediately was able to identify the value of story as a means of education. However, it was not until I was introduced to the Storywork Toolkit did I learn to acknowledge the potential of story as a transformative process. For my part of the presentation, I will share with you the purpose of the toolkit for program utilization, share some user data from the workshop that highlights the toolkit's diverse ability to support many avenues of wellness, and finally, I will share an example of our program's experience implementing the toolkit. When facilitating the story work as professionals, we all have utilized stories to promote connection, reflection, and skill building. There is a natural context within the substance abuse recovery field to honor story is an integrated part of the recovery journey, as Amanda had shared with us earlier. In my experience integrating the Storywork Toolkit, it was an excellent tool that presented content in a dynamic way that allowed each participant to engage in their own story building process, where they became the experts of their stories. This slide talks about our group before the toolkit. I was always mentored to facilitate groups much like a classroom with education, discussion, and skill building. Most often the information I presented was from curriculums that placed me sometimes in the role of being the group expert. For example, if I was doing a group on boundaries, I better have some education on how to facilitate boundaries. Otherwise, my clients are going to completely disengage and think everything I say is irrelevant. So because of that dynamic, I would experience that it was difficult to engage every client as an individual in the process and honor their own stories. It was also sometimes a struggle when the topic felt like they didn't apply to everyone if sitting in the room. So oftentimes we would experience, like I was saying earlier, that clients would disengage because the material was not all-inclusive. Since integrating the toolkit within the last 3 months, we've had nothing but positive feedback. The information is very inclusive as the stories allow opportunities for each participant to communicate their personal stories in a constructive and supportive environment. As a facilitator, I experienced a renewal of my role, transforming from that point of being group expert to now I got to be a supporter. When facilitating the toolkit, like I no longer was correlated with that role anymore. I just got to be a supportive member within the group. And that was a really refreshing change of dynamic because I got to engage with the clients on a more individual manner. This is one of the data feedbacks from the workshop we went to. Within the toolkit, you will find 5 sections. There's story prompts, which are open-ended reflective questions, warm-up activities that provide an opportunity for connection and resiliency building, story circles that assist with building a positive relationship with storytelling, digital stories that are pre-recorded stories on a variety of health-centered topics, and building block activities that offer an opportunity for positive participation engagement. So this is the data that was collected from the workshop. Our program experience reflects positively within there. We did have really great warm-up activities, and we had a lot of people resonate with the digital stories. We learned that the warm-up activities are a positive tool that allows you to build community within your group, and that the digital stories were essential in establishing resiliency within the group dynamics. These are all the workshop topics that were reported back from our workshop cohort. As you can see, the toolkit was utilized to discuss many topics from healthy eating to nutrition and self-esteem and emotional health. I think this talks a lot about the toolkit's adaptability and diverse ability to be able to reach many avenues of health and wellness. On our program, we were able to utilize the kit to facilitate groups on positive self-esteem. We provided education and prevention on substance abuse. We discussed having a compassionate perspective towards self-acceptance and taking control of positive lifestyles. We have also been able to continue utilizing the toolkit and will begin a series on the use of traditional tobacco and a tobacco cessation group. This is just the facilitator feedback. Everyone felt really comfortable utilizing the toolkit and integrating it. This just emphasizes that the toolkit is very user-friendly and highly adaptable and diverse in its purpose of utilization. Now the big question is how to use the toolkit to support recovery program. So the toolkit has multiple components that can be utilized in a diverse combination of ways to achieve the topic you want to present. In the next few slides, I will be sharing with you our program's work with the toolkit and represent a day within our group. So Amanda and I primarily work with an adult outpatient group setting with co-ed group dynamics. For this group, we selected Hold On to What Is Good, which is a pre-planned theme, which includes a warm-up activity, a digital story, a story prompt, and an activity that all correlate and support one another. The goal of this theme was to help participants find ways to value themselves more, decide how they truly want to live, and understand the control they have over their own lives. In each slide, I have a summary of what the activity was and then some client quotes actually from our participants within the group. So this is the warm-up activity. We began the group with the warm-up activity, and it provided an opportunity to allow the group members to connect with one another and hold each other in a really positive regard. This activity was a really great way to prepare the group to be more receptive to the power of the digital story we shared following this activity. The digital short story we shared was Reflections in the Mirror by Jody DeVault. In her story, she discussed overcoming her past to find a healthier lifestyle. Oftentimes when we utilize stories in group, it was very one-dimensional. Stories were either read out loud by the group or an individual from a book or as an oral recollection of personal experiences. With a digital story, the story was presented in a multifaceted experience with pictures, oral storytelling from the writer themselves, and music. This presentation of story was very modernized and easily accessible to all participants, which highlighted the therapeutic value of storytelling in the modern digital age. So each story is followed by an activity. In our activity, we did a personal journey to wellness. In this activity, we asked each client, this activity encouraged each individual to engage in their own storytelling process. And we ended the activity with a story circle that emphasized that our healthy behaviors are behaviors that we have control of. With this, we wanted to instill a sense of power to our clients, when a lot of times our clients report back that they share a feeling of powerlessness over their behaviors. So this activity gave us the opportunity to highlight the fact that we can also control our positive behaviors as well and instill a sense of power for them. So our experience with the toolkit, we've actually had an increase of group participation as clients have enjoyed the content and feel engaged in the process of stories. In addition, it has created a new therapeutic dynamic with the group facilitators, as we have been allowed to let the stories lead the group context. So we have actually been supporters within our group and not the actual facilitator or group expert, like I shared earlier. So once again, we are reminded that when we utilize the toolkit, we are embracing the opportunity to allow a story to become a teacher. And with that, I hand it back to Michelle.
Thanks, Amanda, and thank you, Mindy. So as you all have heard from these two wonderful StoryWork Toolkit facilitators, I mean, they're on fire. They are just really making lots of good gains with their groups with this toolkit. And so when we think about, well, what's next for us, we want to help share this knowledge and help those on the line or within your programs to learn what Mindy and Amanda have learned. So we're going to roll it out this fall. It's going to be a 3-day workshop. It's hands-on. It's very experiential based. You will come away with your own facilitator toolkit, the 11 digital stories, and you'll have some technical assistance from us to use the toolkit as needed. And so we just want to invite you guys, if you see it being useful for your program, feel free to contact us. And so this is the information. You can contact me. Here's my email. I'm Michelle Archuleta, the Health Promotion Area Consultant. And with that, we were just so blessed and honored to be a part of this presentation. So I'm going to hand it back over to you, BC. And Jeff?
Hey, thank you very much, Michelle and Amanda and Mindy. I mean, I think the power of the story is something that I'm sure many of the participants on this webinar can acknowledge, and really looking forward to the rollout and the adaptation in terms of how we can use this as part of our comprehensive treatment system of care, as well as I think really engage in the cultural aspects of treatment and recovery. Along those lines, which leads us to our next presenter, Willie Wolf, who is a member of the Tribal Technical Assistance Center expert panel. Willie lives in Cheyenne River, South Dakota, as a member of the Lakota tribe. Willie is going to talk about cultural approaches to recovery, including the white bison and red road recovery approach. So Willie, please, we're looking forward to your presentation and experience and wisdom in the field for many years. So thank you for joining us.
Thank you very much. Welcome, everyone. Excuse me. It's good to be here with you all. I want to say thank you, Palama, to Michelle and Amanda and Mindy for a wonderful presentation. And, of course, storytelling is a traditional cultural part of our ways. And, so I really I enjoyed hearing what they had to share on that, and hopefully it was helpful to all of you. This is a big topic, hard to do justice to it in the time we have, so what I thought I would do is just kind of focus on a few things that might be helpful to you. They're things that I think most programs use, and share with you some of my experiences with it, as well as many of the inpatient, outpatient programs that I've worked with across Indian country. As was mentioned, I've been blessed in many ways to work with some of the more effective programs out there. One of them is White Bison. I did the first strategic plan back in 1987, and they do work in the areas of prevention, intervention, recovery, and treatment, and helped train the first 150 fire starters in that program back in the 80s and 90s. And then the Red Road approach, and that's been around about the same amount of time, actually. In the Plains area, there are a number of tribes that use that in the schools, as well as in inpatient, outpatient programs. And then there's I've also been involved with GONA, and of course the technical assistance, that's one of their primary training programs, and that's been around since the early 90s, and culture is definitely a big part of their program as well. And so some of the things that you will see in all of those as well, and I don't want to just focus on those three. I mean, throughout the country, there's so many other tribes that have their own approaches, or use some that are relevant in their part of the country. But I would like to start off by a simple thing that is done in a lot of these programs, and I'm sure many of you, if not all of you, are familiar with, and that is smudging. And we do that as a way to purify our hearts and our minds. It's the way that I was taught. And people use different things depending upon what part of the country you're in. You may use cedar or sweet grass or sage, and sometimes people mix them together. So you may have a combination of those or all three. I've seen that done as well. And people do it oftentimes first thing in the morning to start their day off right. But you also use it before you go into ceremonies, even before you do talking circles, for example. And that way it prepares you and helps you to have a good heart and to, speak your truth. And then since I mentioned talking circle, I'll just go into that, because pretty much everywhere I go I see talking circles. Sometimes they call it healing circles. There's different variations of it. And this is also, we have so many beautiful traditions that have been given to us from our ancestors, and that's one of them. And, basically, as it says, you get in a circle and you have people sit, and then it's best to remove all the barriers, so not to have tables around, so people can, there's open space there. Sometimes people have an altar in the middle, and you put down some of your sacred objects, like a feather, for example. It might be a smudge pot in there. You could have some other things as well. It's really up to whoever is facilitating the circle. And people go around. There's some ground rules there. But the main idea is that's a sacred time where everyone can share, and nobody's going to interrupt you during that time. And I've seen some pretty amazing things happen during circles. There's different ways of doing it. You can do it within a certain time frame, or you can just leave it open-ended. But if you're interested, you can contact me after the thing, and I can send you some guidelines if you don't have them already on that. So I just wanted to make that available to you. Another thing that's pretty common throughout Indian country that I found in here in Washington, as well as pretty much everywhere I go, actually, are the use of sweats. We call them inipi back in South Dakota. But the way it was taught to me is this is the womb of our mother when you enter into the sweat. And there's different ways of doing this. Some people kind of get hung up on the rituals, but as long as you do it with a good heart, I was taught, then whatever happens in there will be what's supposed to happen. But it's a place that you go to pray and also to let go of your resentments, and it's where the way I was taught once again is that when you go in there and when you come out, you're not the same person. So in essence, you're reborn. Not in this sense, it's talking about you're transformed. You're not the same person you were when you went in there. And I've definitely found that to be true with every sweat that I participated in. So that's another one there. Then another thing that all these various programs share, I think, is our traditional values, which are so important and a major part of our culture. And for instance, in Gona, they have 4 main ones, which is you learn about a sense of belonging and mastery, interdependence, and generosity. And then the whole curriculum is built around those 4 different traditional values. And so it's important that people learn about those, because sometimes they might have learned about them earlier in their life and then kind of gone away from it. And then this way they can begin to understand why each of them are so important. In regards to the one on belonging, another thing that you see in all of these programs is a version of what we call a cultural genogram. And I think that is very, very important to have clients do. And it's a way for them to find out what their clan or their band is. And then once they do that, of course, then they understand their family history more, and they have a stronger support system, and they get more connected to their extended family. And that's very, very, very important, and it's part of their healing journey. So another thing that I wanted to mention was as brought up earlier with the previous presentation on storytelling, was the digital storytelling, was the emphasis on historical trauma. And that's built into all these programs and many others. I think throughout Indian country, people understand how important it is to address that. And that's looking at some of the things that have happened to our people that have oppressed us and have tried to break down our cultural strengths. One is the boarding school syndrome, and Dr. Maria Braveheart says that the source of all our dysfunctional behavior comes from the boarding school experience. And from my having done a lot of work in that area, I would certainly agree with that statement. So I think that needs to be an integral part of any prevention or recovery program that you have. And I also believe that it's one of the main reasons when it's not there or it's not done the right way is why so many of our people end up relapsing, because they haven't dealt with some of the underlying traumas that are still impacting their lives in so many ways. And just to give you an example, another program that's out here where I am in the Northwest, That's not one of the three I just mentioned. It's what they call the canoe journey, and that's where a cultural tradition that was brought back in 1989, and canoes are very, very important, the cedar canoes out here in the Northwest, and so it's kind of like their whole ceremony was built around that, and they would stop at different places, and they would do trading, and then they'd have songs, and people would do storytelling, and they'd have a potlatch there, and so they brought this back, and it's kind of like become, for the younger people, a rite of passage. And one of the tribes in the area here actually developed a whole prevention curriculum around it, and they use it, and they have a module just on dealing with opiates in there. And it's going through the process now, becoming evidence-based, working with the University of Washington. So that's very exciting because we don't have very many programs that are evidence-based. So that's been very, very powerful for the tribes here along the coast. And so those are some of the things that I thought I wanted to share with you. Oh, one other that I wanted to mention as well is that comes out of the plains area, but tribes throughout the country have adapted a lot of these things. Like in one region of the country, they have something that works, and then other people pick it up. And I think that's that I don't have a problem with that. Some people are like, well, that's not our way, but we always borrowed from other tribes. Like when on the powwow circuit, for example, the jingle dress dance came from the Anishinaabe people, but now you see it in powwows wherever you go throughout the country. So that's just cultural sharing, and same thing with all these other things. So I think that's how I look at the medicine wheel. It was traditionally a symbol of wellness for our people, and it represents in the inner circle, I won't go into all of it, but the mental, the physical, the emotional, and the spiritual. So it's a holistic approach to recovery. And it's built into a lot of all these programs that I mentioned here previously. And you see a different version of that among the Dene people in the Southwest when they have the beauty way, but you see a lot of the teachings of the medicine wheel in there too. I've seen a lot of similarities there. So anyhow, there's a lot of really good programs out there that are available. And the one thing I did want to mention to you all is that when you have people doing some of these things to help you out, like spiritual leaders, for example, you really have to do some careful screening to make sure you have people who know what they're doing, because some people are not who they say they are. And we have what we call false prophets among our people. And so you can do more harm than good because there's a lot of sacred energy with all these things. And you just have to ask the people in the community who they respect, and they'll know. They'll tell you who you can trust and who really knows how to do things the right way. So, make sure you ask them so that they will guide you to find the right person to help you with that particular ceremony or ritual that you want to use in your program. So I think that's what I wanted to share with you all for right now.
Thank you very much. Really appreciate you. The clear explanation not only of the rituals, but the meaning behind the rituals, and as well as some of the sensitivities, as you sort of last mentioned, in terms of understanding the appropriate individuals in our tribal communities who could administer and facilitate some of these. So I want to thank you for tying that together with our storytelling. We want to end our the third part of this series with a presentation from Dr. Annalene Skinstad from the SAMHSA Addiction Technology Transfer Center that focuses on Native Americans and Alaskan Natives. Anne's going to talk about some of the resources from her Training and Technical Assistance Center that might be useful, some of the particular technical assistance that might be available, and really then also some opioid-specific information that might be valuable for the participants on today's call. Anne, you want to take it from here? We'd be pleased.
Thank you very much, Dr. Cody. And I want to highlight for all of you that Region 6 is not what I was intended to include in my title here, but Region 5. Sorry about that. I am the director of the National American Indian and Alaska Native Addiction Technology Transfer Center, a mouthful. And I happen to be Norwegian, so I'm sure you hear my accent in the middle of everything. However, I have worked with American Indian communities in the upper Midwest and nationally for close to or over 18 or 20 years. And Dr. Cody indicated what I'm going to focus on in this presentation. And what I'd like to say is that we are a SAMHSA-funded grant, and we are very happy to be a SAMHSA-funded grant. And some of what I might say does not necessarily reflect the view of our funder. We are part of a national network consisting of 10 other regional centers, and I know we will soon have another Hispanic Latino ATTC center. So for those of you who are outside of Region 5, please look at the map and find the regional center that you are connected to, and look at their program through the ATTC network website. We also now have 4 international centers, and they are focusing primarily on trying to reduce the HIV epidemic across the world. So the ATTC network has taken on a very different and more expansive role since 2017. I wanted to take the time to introduce our National American Indian Alaska Native ATTC and start with our mission. And what we really want to try to do is to be a national subject matter expert and gather resources on adoption of culturally informed and experience-based addiction treatment and recovery support services, and also support the regional ATTCs in their efforts to work more closely with the Native American and Alaska Native communities. And we want to make sure we enhance and promote communication and collaborations between the Native communities and the ATTC. We conduct regular needs assessment to make sure we understand what the needs of our providers are. And this issue of evidence-based, experience-based knowledge and cultural sharing are things that we think are very important. And I want to add something to that, because when we talk about evidence-based, that's really Western-based. Native communities have much longer experience in doing research than the Western community. It's just that it is in the stories, in the experiences that you share between each other, rather than yanking out a lot of numbers. One thing that we also try to do is to use technology in our efforts to do this. However, that's not usually the preferred method for Native communities. So we try to do a combination of that. We are a workforce development center, And that means we also provide technical assistance to individual tribal communities, providers, or the ATTC network. And we are very much focused on recovery support. And our previous presenter talked about the Red Road, and we have been involved with supporting the Red Road approach for very, very many years, and will continue to do that. I'd like to introduce our staff, our collaborators, and our consultants. And here is the home office, the ones at the University of Iowa, and we have different roles, and you will see our names connected to many of the programs that we implement, and we have a lot of consultants across the country because we want to make sure we are connected to communities outside of Iowa. So Dr. Walker, a psychiatrist, has worked with us for many years, and most of you may know him as the director of the One Sky Center, which is a web page, a resource center that over the next 5 years we will merge into our resource center, or vice versa. I don't know how it's going to look quite yet. Dr. McCoy is our evaluator. Ed Parcells has worked with us for very many years and is the curriculum committee chair. And Matt Ignazio also has worked with us for many years on LGBT Two-Spirit initiatives. There are some more of our collaborators. I want to highlight Professor Norman at Harvard, who is really going to work with us on enhancing collaboration with tribal colleges and universities. We have a lot of national activities going on, and we work with Alaska Native Tribal Health Consortium because we specifically want to support the behavioral health aid program and see how many in the lower 48 states would be willing to work with us on that. We also work with the Northwest Portland Behavioral Health Board. University of Miami is our collaborator on evaluation, and we also have included Healing to Wellness Court. The Association of American Indian Physicians are very important in our collaboration, especially because of the opiate addiction that we see across Native countries, and the Center of Excellence in Telehealth. Academic programs, I mentioned Dr. Norman from Harvard. We are going to include one tribal college or university a year to work on curriculum development, etc. And also to work with faculty members who teach primarily Native students, but not necessarily through a tribal college or university. We do a lot of technical assistance, and one of our projects I want to highlight is the suicide prevention efforts that we have had and worked with one tribal program with. We provide newsletters, and the last newsletter was on Healing to Wellness Courts. The next upcoming newsletters, two actually, will focus on adolescents and have both a mental health and a prevention perspective in the articles we include. We have taken it very seriously that spirituality is very important in behavioral health. And I liked the reference to good medicine and bad medicine. That came up through our first spiritual roundtable discussion that one of our distinguished elders was very particular in saying exactly the same. Not everything is good medicine, and we need to make sure our tribal providers can differentiate this. We run a Native American Leadership Academy, and the pictures to here are from two different cohorts. On the left is the graduation session for our first cohort, and on the right is the beginning of the second cohort, where we had 10 mentees and 10 mentors, all of them native from different parts of the country. It's a very good program, and we're going to start recruiting very soon. We run 2 behavioral health and a essential substance abuse skills webinar. And the first one, the behavioral health webinar, is very often planned according to what our providers want us to address. So any input you have, we would really appreciate it. The second one here is really focused on trying to increase the number of providers, native providers, who can be licensed or certified and then be able to get third-party reimbursements. We created a set of consultants, team consultants consisting of members of our advisory council and graduates from the Leadership Academy and also collaborators. And there's one thing that I want to highlight that we decided was going to be a theme that we wanted to focus on, and that is how to take care of yourself as a counselor and as a professional, knowing well that some of us have experienced traumas and will be really exposed to that through listening to our native clients with behavioral health disorders. We have developed a curriculum that is really developed primarily for non-natives. However, what we discovered very quickly is that a lot of native providers also feel that this is useful information. In other words, how to understand and include spirituality in the treatment and also be sensitive to that. Ethical issues in Native communities are very important and really challenging. So we have a specific course focusing on that, as well as a specific course focusing on culturally adapted training program on clinical supervision. We've talked a little bit about this. The highlight of this is that I would like to build a capacity in the regions across the 10 ATTCs and also the 12 IHS regions to see if I can train, or we can train as many native trainers as possible, and then through them and with our support can offer some of these basic training programs on a very regular basis in each and every one of the regions. So anybody online who might be interested in this, please let me know and we will connect with you. I'm going to go through this not very thoroughly, but briefly, because I know that already there have been 2 sessions focused on opiate addiction, and especially in Native communities, and sort of highlight some of what I think would be important to know when we start planning initiatives in our provider agencies. And we do know that there are a lot of different forms of medications prescribed for pain control, for anxiety, for ADHD, and many of them can be abused. And oftentimes we know that our primary care docs have not really grasped the importance of how to educate our clients on tapering off, limited time for when these medications are taken, etc., and not sharing with people who haven't been prescribed the medication. Here are some of the opiates that have been abused, and what I want to also add, and I know you all know about this, but fentanyl, I may not pronounce it correctly. Synthetic opiate is very dangerous, and so is the version that is used by by veterinarians, cofentanyl, which is very, very much stronger. And I've seen it in tribal communities in Maine and New England. So it's something to be really cognizant of. And we know something about how opiates are experienced, how we can see symptoms. But the main thing is tolerance and withdrawal are developed very quickly. And unfortunately, a lot of our clients combine with other medications to create a cocktail that is very dangerous. And I want to specifically highlight the combination of opiates and used with benzodiazepines and with barbiturates. And unfortunately, our barbiturates are in some communities coming back and also very, very dangerous medications. What we unfortunately know is that when we try to describe prevalence of abuse, it's very hard to know the numbers. And the reason being that many tribes do not have data that is reflective of the epidemic in their community for many, many reasons. And one of the things that we want to do with our ATTC is support TA in trying to help tribes start collecting data, because by having data, you make yourself much more competitive in the grant writing business. And that's part of what we think are very important. Methamphetamine is, at this point, a forgotten drug, but unfortunately claims as many fatalities as the opiate addiction does. And I think it's very important for us to keep a very close eye on that and know that both opiates and methamphetamine are unfortunately associated with HIV transmission and AIDS. A lot of these medications are prescribed because of our clients being in pain. And sometimes they are prescribed when the clients are in recovery as well. And we know that many of our clients in recovery are very concerned about that because of the cost tolerance development. And we know that there are many, many reasons: historic, generational trauma, ongoing traumatic situation in the community, falls, accidents, abuse, sexual, physical, and emotional, all being experienced in tribal communities and also contributing to the pain, physical pain, that a lot of our clients have experienced, and which our doctors often prescribed opiates or benzodiazepines for. When it comes to what we do with substance abuse in our native communities, there are a number of things to consider. And here is a wonderful picture from a health summit offered in the Portland area IHS region. And I think thinking about the importance of community, it does take a village, and I think that's one of the things that this picture really shows us. Because what we do when we help communities across the country is to really use what we call community-based participatory research and programming. That is, we ask first, we listen first, and then we start developing in collaboration with the community strategies that we want to support the community in implementing. That being said, it is very important to look at this from a strength perspective and not only a deficit perspective. Regardless, we can't not think about the problems we have when we want to build on the strength. So we need to know all what parts of the country the tribe is from, what kind of rituals, ceremonies they use, but also be aware of what was said earlier, that there is a cross-cultural sharing that I think we also need to be very, very cognizant of and supportive of. And we have a curriculum here that really focusing on understanding where our clients are coming from. Are they coming from a traditional perspective, a bicultural perspective, or a assimilated perspective? And that will or should guide our treatment planning and work with our community. We need to know how many people in the community live in poverty, and unfortunately, we know that the Native communities are really struggling with poverty issues. We need to know something about health disparity and mortality rates. The main thing here is that the health disparity in Native and urban Indian communities are very serious. We need to think about this from a health disparity perspective and a chronic disease management, and not focus on the acute situation when we meet our clients. And we also need to know that some communities have limited access to a lot of what we in Western communities take for granted, and that several of our tribal members have poor access to health insurance. There is a lack of federal funding or funding in general, and some tribal communities are concerned about the quality of care they receive. But in the middle of this, let's look at making sure that we understand the difference between what is traditional and what is non-traditional, or a Western way of doing business. But the main thing is, and I think I want to highlight this, and that is that indigenous knowledge is protected by the World Health Organization, and tribal communities may need to think about what that means when you implement traditional practices into your Western evidence-based, experience-based treatment approaches. When I switch gear now, I am talking about treatment approaches, and one of the main overriding theme of any treatment approach should be trauma-informed care, and think about what trauma this person has experienced, how many, how overwhelming this can be, and also think about, is this a veteran? Is this a veteran who comes back from combat and who may have complex traumatic experiences that need to be addressed. And also, I think we are very fortunate in Native communities because a number of the Native communities have specific ceremonies for returning veterans, and I think it's very important to reinstate those. Here are SAMHSA's concept of trauma-informed systems. We need to understand the impact of the trauma, the signs of the trauma, the application of the response to the trauma, and be careful with re-traumatization. And with that, I'm also thinking about our own staff. We provide training in motivational interviewing. And when I'm saying that, we have taken in a training program and made it culturally informed, and we call it the spirit of communication, and we are updating it to the 3rd edition of motivational interviewing. We have provided cognitive behavioral therapy training and tried to do it culturally informed. The same with community reinforcement, where the community is involved, and we know that when tribal providers return from treatment, their ability to connect to the community increases their recovery so much more. So the need for connecting to the tribal community is very, very important. And of course, we can't forget medication-assisted treatment for different kinds of substances outlined here, and also look at, are there any access to naloxone in case of a opiate overdose? And
this is Jeff. I know you're about to finish up, but I know we have about 1 more minute, then we're going to wrap it up, please.
I'm just going to remind them, Jeff, about ONDCP's 4 pillars of an action plan that, you know, you and I have worked on before, and the community needs to include these 4 pillars in their efforts to develop a recovery plan for the community when it comes to opiate addiction. So here are some of our products. This is the result of a symposium we did on that 4-pillar ONDCP model. And this is something we just published, Reclaiming Our Roots, Rising from the Ashes of Historical Trauma. And then I wanted to highlight this, TAP 21, which is a program we took and culturally adapted and provide clinical supervision. So with that, I am finished, and I leave the rest to you, Jeff. Here is my
Thank you, Anna. Appreciate your time, your commitment, and the resources that you have developed. If individuals were interested in some of the specific resources or additional technical assistance, is the best way to contact you via email? How would they go about that? I know you have contact information there.
I think email is very good. I also think that it's important for our participants on this webinar to connect with the ATTC network and see what is there too. You can find us there as well. So either way is fine with us.
Thank you very much. You know, I'm sort of been following some of the chat box, and I know there's been a couple different questions, some related to follow-up related to the digital stories and the toolkit and the additional 3-day workshop that's going to take place, and I saw some tentative dates. Michelle, is there going to be any other opportunity for the sharing of that toolkit? Will it be published? Is there going to be like a YouTube or webinars or other ways that folks who might not be able to participate in the 3-day workshop have access to it?
Good question. We have our stories set up to be on YouTube, on the IHS channel, and those coincide with the toolkit. We'll probably upload some dates for workshops on our ihs.gov HPDP website. And in terms of going out to tribal communities or area programs, I mean, we have those 2 dates planned already now in Albuquerque and in Minneapolis, where we'll do a 3-day training, but we can go to other tribal sites also. And that's kind of how we roll out our workshops. Do you have any suggestions of what we should do with, I guess, for more information?
You know, I'm going to defer to the participants on the, I'm seeing someone right now maybe tapping in the chat box in terms of how some of the best way to disseminate and uptake if folks are interested in their tribal community. How might we be able to access that? So I don't know if folks want to maybe chime in terms of how we can get these resources to you. I know that as Anne Helene rolled out a lot of good information, I think one of the hardest challenges we have, there's much information, try to have a one-stop shop or format that we can most readily get the information to the tribal partners. You can see BC said, you know, that's what BC is, they could share it definitely through their network as well.
Yep, and I think I'll contact, the guy, I forget his name, at headquarters with behavioral health, the telehealth.
Yeah, Chris Four.
Yeah, there you go.
Yeah. Mm-hmm. Exactly.
The other Chris.
So I think it's a very good idea, depending on where you want to offer a face-to-face, to contact your local ATTC as well. And if you do that, CC me, and I can follow up with them afterwards, because they will be supportive of this as well.
That's a great idea.
You know, I'm seeing a couple of different comments in the chat box. I see Anne's going to reach out to you related to motivational interviewing. I know you mentioned in relation to trauma-informed care, and I think that, you know, regardless of the provider, whether it's behavioral health, whether it is, you know, front office staff, whether it is your primary care providers, the skills of motivational interviewing certainly are valuable. Even, you know, parents, in terms of being able to have conversations with your child sometimes. I know that, you know, just in terms of having to not create a dynamic that is adversarial, but more shared decision-making and helping empower people in that process. So it's nice to see that's going to happen. And I also saw Barbara talking about a digital storytelling for LGBT attendees in Alaska, sponsored by the Center. Thanks for sharing that, Barbara. That's good information. And Kit, yeah, certainly I think the SAMHSA GPOs and the Tribal Tech folks can send a copy of the toolkit when it comes out. I mean, I think it's something we certainly want to be able to share as broadly as we can through the different connected points that you had to have to some of the federal partners on the phone.
Let me add something to this also. We have a curriculum on Native LGBT Two-Spirit people with behavioral health disorders that are in the final stages of being finalized. And when we finalize that, we already have trainers across the country and even in Alaska. I heard Alaska was mentioned. So that would be something we would be more than happy to share with this group as well.
Excellent. Thank you, Anne. It's a nice segue into the other resources. You know, one of the questions I guess I want to pose to the folks who are on the call is we're looking to have a fourth webinar, hopefully on June 20th is the tentative date, same time. And what we wanted to have on that webinar was really a town hall. You know, you've heard, I think, for those who've been part of the whole series, we've heard about, you know, different models, I think, from many of the tribes and tribal partners that have been working, heard about many of the different resources where to access some of these different technical assistance and information. But as we continue to take a step, I think more hearing from where might be tables, what are we missing, what are we not funding? I mean, trying to get some of that additional information in a town hall. I think town halls are meant for not for the presenter to talk during the whole town hall, but for to have listening conversations. So many of the conversations that are happening in the chat box would kind of be the would be a source of information of how we can sort of structure that town hall. So I don't know if any individuals had areas that they might want to have further addressed in a town hall format or subsequent webinars, any topics that we seem that information might be valuable.
Jeff, I noticed that we do have a raised hand. We do not turn on the audio, unfortunately, so if you'd like to type your question or comment in the chat box, we'll be happy to discuss it. And I don't know, Ann, if you saw Lori Sampson mention that she would like to contact you later about motivational interviewing skills in regards to trauma-informed care. So we know you'll look forward to that contact with Lori.
And that's great. We are in the process of updating it to the 3rd edition of motivational interviewing. So until then, we will not offer it to face-to-face. However, I have several trainers who are ready to train and do that as soon as they have updated the curriculum.
Great, thank you.
Michelle, I saw a question for you in the chat box related to sort of the preservations of the stories. Is that something that Bemidji has been able to resolve?
Oh boy, that's not a unique situation across our areas, because they've done a lot of great work out in California with the health promotion area consultant, and over in Albuquerque and Navajo. No, the answer is no. The only thing that we can do is establish maybe a dedicated health promotion site on YouTube where we could upload those stories. But here's the problem. The problem is when we do that, we're told that they have to be 508 compliant. So when you do a workshop, you have to have the intention to make sure that these stories, before they're finalized, have the the text embedded into the slides before we finalize, or it's kind of a headache to do it after. So that's just something, and then there was all kinds of issues around waivers, and it just kind of got a headache for, I would say, us as health care. But I think because of the trend of using digital stories and really digital stories coming into their own as an intervention, we're starting to be more flexible with it. So it's still being worked out, but those are, yeah, it is kind of a problem still.
Okay. Yeah, but I think sounds like you're working on it, but I think the sensitivities, obviously, in terms of the importance of someone's story and them owning that story is certainly, I think, you guys take great consideration and sensitivity to that. So I certainly want to acknowledge that.
Yeah.
So,
and we also use stories in our featuring of Recovery Month. And we had the same issues and the same need for sensitivity, because these people were sharing parts of their life.
Thank you, Ann. Really good to tie into the Recovery Month and the sharing of the story. I know we're about 1 minute left, and I want to give time to BC and other presenters for any kind of closing thoughts. I know Megan is typing away as we're speaking, or maybe not, but BC, I'll hand over to you for sort of closing thoughts and housekeeping, if there is.
Thank you, Jeff. No, one of the housekeeping notes you did cover, and that's our part 4 of this session, Opioids in Indian Country. And we really do, when we send out the invitation for that, it will include a request for any kind of question or comment for any of the participants in the last 3 sessions. Even though they all may not be able to join us, we hope to at least present them to them, and we'll share their answer on that call. And I really want to give a shout out to Mr. Willie Wolf for joining us today. It was a very, very last minute request. We unfortunately had a cancellation, and I can't thank him enough for joining us. So until next time, we look forward to you joining us all. Thank you very much for being with us.